been a nurse for 15 years. I work at Catawba Valley Medical Center. I have background in orthopedic nursing, inpatient rehab, case management, discharge planning, and I'm talking to you guys today about postpartum care. I don't have postpartum in my background, but like what Ms. Caldwell and Ms. Kiesler say, your med-surg background, your basics will follow you throughout all of your patient population, from your pediatrics to your geriatrics. So I know a lot about my med-surg, and we're going to tie those together and tailor those med-surg topics today into postpartum complications. So first off, our objectives today, you learn, which is you guys are going to be able to recognize the signs and symptoms of postpartum complications to your patients. You guys are going to be able to implement interventions related to the treatment of postpartum patients and to the complications that they encounter. And you're also going to be able to discuss patient education. Patient education is a big deal whenever you have patients with complications. So we're going to learn some patient education topics and be able to take care of those patients. So our first topic today is thrombosis. Like what Ms. Caldwell says, what is it? What is a thrombosis? It's a blood clot within the vascular system. It's also known as venous thromboembolism, VTE. VTE occurs in 900,000 people annually. That's a big number. And over a third of these VTE cases can lead to death. So this is a very serious thing for having these thrombosis, these blood clots. This is broken down into three different sections. SVT, which does not stand in this case for supraventricular tachycardia for your cardiac patients. This is more for the thrombosis. This is superficial venous thrombosis. It's in the saphenous veins or the superficial veins. Also DVT, deep vein thrombosis, more in the deep veins. And that could be anywhere throughout the body in the deep veins, but mostly we focus on the ones in the bilateral lower extremities. Also thrombophlebitis, which is a clot that's formed in response to inflammation in the vein wall. How can you get a thrombophlebitis? Can somebody tell me how a thrombophlebitis can occur? Anybody have any ideas? Infiltration of the IV site. The inflammation from the infiltration of the IV site can lead to thrombophlebitis and then can lead to a blood clot. So what causes thrombosis? Particularly in the postpartum patient, it's the increasing clotting factors of fibrinogen during pregnancy and during the first 6 weeks after delivery. Also, there's other risk factors that include C-section births, endometritis, immobility, multiparity, trauma to any extremities, varicose veins, advanced maternal age. Anybody over 35 years of age is at risk for that. History of coagulation disorders. If they've been on hormone use, they've had replacement or oral contraceptives, and then also diabetes is a big risk factor as well. So what are you going to see as a nurse? Your signs and symptoms from SVT, you're going to see localized redness, tenderness over that superficial vein. For a DVT, you traditionally see utilized leg pain, so just in one leg traditionally, that extends up above the knee, mainly in the calf areas where you'll see that tenderness and swelling. You can also see a positive Holman sign. Does anybody know what a Holman sign is? Can someone tell me what Holman sign is? When you dorsiflex and they feel that pain in that calf area, that's a positive Holman sign. Also, low-grade fever and chills could be a sign as well. Diagnostic tests, what are you going to see? What confirms a DVT? That venous ultrasound, exactly. So we'll get the physician to order that to confirm that there is actually a blood clot there at DVT. So that goes into your nursing interventions here. What are you going to do about it? This is an emergency. You do need to call the physician immediately. We need to assess for edema, assess the peripheral pulses, temperature, color, and tenderness every 8 hours or more often if the patient is complaining of signs and symptoms. Assess that Holman sign. Maintain bed rest during the acute phase. Why would we want to keep somebody at bed rest if we think they might have a blood clot? Absolutely. Absolutely. And how does that happen? Absolutely. When they get up, those muscles in the legs, they contract around those veins, and it brings that blood clot up to the heart, brain, or any place else like that. Absolutely. For comfort measures, you want to provide warm and moist compresses and elevate that affected limb as well. So what are we going to do about it? Treatment, medical-wise or medication-wise in the hospital, they're traditionally put on heparin IV drip. It's an anticoagulant, unfractionated heparin. It is dosed by weight-based nomogram. Labs, they check PTTs every 4 to 6 hours. And for that level of the PTT, that's when they'll adjust the dosage of the heparin IV drip. This is also started in the hospital to help bridge long-term Coumadin or warfarin at home. And the therapeutic level that they want to get the INR level up to is above 2.0. Also, another treatment for that they're doing more often too is sub-Q Lovenox, enoxaparin. This is something that they'll give in instead of giving a heparin IV drip, because the patient can go home on Lovenox. It is an anticoagulant. It is the low molecular weight heparin. And the dosage is 1 milligram per kilogram every 12 hours for a 7-day treatment therapy session. And traditionally with Lovenox, there is no labs needed. I'm going to bring into this a little bit of case management. Does anybody know what the cost of Lovenox, the actual brand, would cost for a patient that pays self-pay?
It's like $600-$700.
Yeah, it is expensive. Actually, what it is for a self-pay patient, it is $1 per milligram for Lovenox. So somebody like me, I weigh 180 pounds. If I was to take a 7-day course of this, it would cost me out of pocket over $1,100. And I don't know about you guys, but I can't just drop $1,100 at one time for a prescription. So just be kind of mindful of that, because we do get self-pay patients into not just postpartum area, but also just through the general med-surg area. We get a lot of self-pay patients, and they don't have coverage, so it's going to be very expensive. Also, our Medicare patients, if they don't have a drug plan, there's no coverage for them, so they'll be paying out of pocket as well. So if you have somebody that's having financial issues or can't afford their medications, who's somebody that you can reach out to in the hospital that can help? Good. Case management, social worker, and they can do things like that. Awesome. Okay. So for thrombosis, the long-term treatment, like I said, is warfarin or Coumadin, and it is an anticoagulant. It's a vitamin K antagonist, and they usually dose it daily. And again, the dosage depends on the INR level as well. In the hospital, the therapeutic INR is 2.0. In the hospital, they'll draw daily INRs to make sure that they get that therapeutic INR. And once they go home, if they do have an acute DVT, they'll more than likely have the patient come back into the physician office within 2 to 3 weeks to get the lab drawn as well. But after that, it'll be monthly. And then you also want to monitor and educate your patient about avoiding vitamin K foods. So we're bringing pharmacology into this. Why is vitamin K so important when the patient takes Coumadin? Absolutely, yeah. And what are some vitamin K foods that you would tell your patient to avoid? Spinach.
Avocado.
It's not like green leafy vegetables, so like the spinach, kale, mustard greens, collard greens, things like that is the main thing. But there is some in avocado. It's those main green leafy vegetables that you want to tell your patient to avoid. Also, patients that are on anticoagulants, we want to monitor for signs and symptoms of bleeding, and those include unusual bruising, bruises that develop with unknown cause and they grow in size, any nosebleeds, bleeding of the gums, coughing up blood, pink urine, because that shows that there's blood in the urine, red or black stools, or vomiting blood that looks like coffee grounds, so coffee ground emesis. All those are signs and symptoms of bleed. And you as a nurse want to watch for these while they're in the hospital. And along with that, you want to teach your patient these signs and symptoms when they go home as well. So for patient education, teach those signs and symptoms of bleeding. Stress the importance of medication adherence and lab work adherence. Lab work for warfarin. why do we want to stress the importance of making sure that they take their Coumadin daily and that they follow it in their labs? Because with Coumadin, because they have a blood clot already, and if they're not taking their medications, they're, set up to get more blood clots. So you really want to just, emphasize the importance. Take your medications daily and make sure you do your follow-up appointments and get your follow-up labs completed. Also, reporting worsening signs and symptoms to your healthcare provider. And then also call 911 for any difficulty breathing. Why would we want to stress calling 911 for any difficulty breathing for your patient? Okay, that DVT could have possibly moved up to the lungs, absolutely. And then for prevention techniques, to prevent thrombosis, you want to encourage your patient to wear their compression stockings, wear those TED hoses, SCDs, encourage getting up early and frequent ambulation to get that blood moving. And then also foot pump exercises. Does anybody happen to know what a foot pump exercise is? I see you doing it, Dana. What is it?
Pressing on the pedal and,
That's it, pressing on the pedal and letting up on the gas with your feet, because what it does is it gets those muscles and those calves contracted to get that blood back up to the heart. Absolutely. Okay, so our first question here regarding thrombosis, you have a postpartum patient that is at high risk for delivering thrombosis up until how many weeks after delivery? Is that A, 2 weeks, B, 4 weeks, C, 6 weeks, or D, 8 weeks? Absolutely, 6 weeks up to delivery. Absolutely, good job. All right. Okay, so we're going to get started with the case study. I'm going to start off with Jane is the 40-year-old female. She is gravid of 3, parent of 2. She is at 41 weeks gestation. She admitted to the hospital for induction of labor. This baby is not coming out. Her weight, she's 260 pounds, and she is 5'2". Jane has a history of diabetes, and her current blood glucose reading is 185, 2 hours postprandial. She is prepped with her hospital gown. She has her IV site started, and they have began a Pitocin IV drip. The nurse encourages Jane to get up and ambulate to help facilitate labor. She refuses. After about 12 hours on the PIT IV drip, Jane is only dilated 2 centimeters, and she is only at -3 station. Jane's tired. She's been laboring for 12 hours. Nothing's going on, so she requests that the Pitocin drip be turned off for the night so she can rest to start induction again the next day. So in the next morning, Jane's nurse restarts the Pitocin IV drip, and again she encourages her to get up and ambulate again to progress labor. Again, she refuses. After another 12 hours of induction, Jane's only dilated at 4 centimeters, and she's at -2 station. The fetus then begins experiencing fetal distress, and the fetal heart rate decreases to dangerous levels. Jane has a Foley catheter placed. She received an epidural, and she is rushed to the OR to undergo an emergent C-section. Jane has a beautiful bouncing baby boy. 6 hours after Jane has her Foley catheter removed, she is unable to void. What is this condition called? Good, urinary retention. So what are some possible causes of this urinary retention that Jane has experienced? There you go, prolonged catheter use, anesthesia, and what did she just undergo? C-section, yes, absolutely. So what are some interventions that can be used to help Jane overcome her urinary retention?
peppermint oil.
Peppermint oil, good job. What are some other things? Absolutely, getting up, encourage ambulation. It's a possibility, but there's some other options too that we can use. What are some other things? There you go.
Increased fluids.
Increased fluids can help some too. What are some interventions that the nurse can do to help her overcome this urinary retention? Run water, sits bath, absolutely. We do more peri-care. Sit ice packs, that's right. And what if she's still unable to void? We can do a bladder scan in and out, but that's at last resort, correct? the least invasive is what you want to start with at first. Okay, so Jane, bless her heart, she is unable to void, and she has her catheter replaced for a second time. Jane's nurse encourages her to get up and ambulate, but now with her having a Foley catheter in place, Jane states, I have no need to get up. The baby is out. I've got this tube to pee in. So what would be your response as a nurse to Jane when she says this? Uh-huh. And then also, she's at increased risk for what else? UTI. And DVT, good, because she has refused to get up all this time. So with this, Jane's been refusing to get up and ambulate all the time. So as a nurse, there's some things that you can work around. Whenever you go in to ask a patient, watch how you word your questions. So instead of going in to ask Jane, do you want to get up? What is Jane's options? Either yes or no. That's it. So instead of phrasing it that way, think about phrasing it as, come in and say, Jane, when would you like to get up? When would you like to get up? It gives her options. Before breakfast, after breakfast. Before I feed the baby, after I feed the baby. Before I watch the Kardashians, after I watch the Kardashians. So it gives you a multiple array of times instead of just yes or no. And so that gives her the last option of never, because who's going to say, I never want to get up and walk again? So it's just on how you kind of phrase things. So instead of saying, do you want to get up, say something like, when would you like to get up? So that's just a little thing just to remember.